Dear colleagues, welcome to the first webinar of the Union of European Phoniatricians and the European Academy of Phoniatrics. I'm glad to present to you some practical aspects of neurolaryngology that play a role in our daily work. The structure of this presentation refers to motor innervation, and we may distinguish three main groups. We deal with the unilateral and the bilateral vocal fold paralysis and the paralysis of the cricothyroid muscle. Among neurologic diseases in the larynx, we also have functional innervation disorders such as spasmodic dysphonia and inducible laryngeal obstruction. The inducible laryngeal obstruction itself is a rare but a serious case, and it's especially important in sports medicine where they have observed it many times. And this induced laryngeal obstruction has many different names. There are over 40 terms, and just to give you an idea how they may be called, I will show you now the next 3 or 4 slides where you see that there's always something like vocal cord dysfunction, dyskinesia, or spasm, or stridor, or vocal fold dysfunction, vocal fold motion, and so on. And one expression that I really like is the paradoxical vocal fold movement. That means that the vocal folds move in the wrong way. They close during inspiration and they open during expiration. And you see a lot of different names for this inducible laryngeal obstruction. And now we can ask, what are the reasons? So first of all, the reasons are unknown. So, and there are some suspicions that there is an overactive protective reflex or that it's a behavioral predisposition. We also can think of some neurosis like conversions or psychiatric diagnosis, or we also can think of dysfunctional increases in muscle tension or an increased supraglottic tone. I will show you a very severe case where a lady who suffered from this laryngeal obstruction had to be tracheotomized because she could not breathe anymore. So you see she has been tracheotomized already, and when you look through the stoma upwards to the vocal folds, then always during inspiration she closes, and during expiration the vocal folds abduct and the glottis opens. This is one of the rare cases, but really severe. Imagine that you have an intact larynx, and anyway, you still have to have a tracheostomy, and voice is also very much impaired. So how can we diagnose this disease? It's actually, in sports medicine, they suggested to do a continuous laryngoscopy during the exercise with flexible optic, but this is not always possible. That's why you have to rely on what you see in your office when you see the patients. But what can you do? There are behavioral interventions like speech therapy, biofeedback, self-hypnotherapy, or psychotherapy, where the efficacy of all of these measures is not proven. So let's come to the next, which is spasmodic dysphonia. Spasmodic dysphonia, known to many of you, it is a voice disorder that causes involuntary spasms in the larynx, and it affects the voice sound. And the voice tends to become tight and strangled. And the problems range from trouble saying a word or being not able to talk at all. It's a lifelong condition, but it most often occurs in women at the age of between 30 and 50 to 60 years. The treatment of choice for spasmodic dysphonia is up to now botulinum toxin, and it can be applied transcutaneously or transorally in local anesthesia. And what we usually do is we apply a dose of 2.5 units of botulinum toxin, of Botox. I would like to give you an example of the voice of a lady who has this spasmodic dysphonia had for at least 30 years.
Der Nordwind und die Sonne. Einst stritten sich Nordwind und Sonne, wer von ihnen beiden wohl der Stärkere wäre. Als ein Wanderer, der in einen warmen Mantel gehüllt war, des Weges kam. Sie wurden einig, dass derjenige für den Stärkeren gelten sollte, der den Wanderer zwingen würde, seinen Mantel abzunehmen.
Okay, I think you have heard this pressed voice, and this is actually that kind that needs to be treated. And here you see the treatment with botulinum toxin with a syringe, and we have a little needle with an electrode on it, so that we can really find and identify the thyroarytenoid muscle. We go in the space between the cricoid and the thyroid through the cricothyroid ligament into the muscle, and then we inject the botulinum toxin into the muscle when we receive some summation potential from the muscle during phonation. And here is the setup again. So we did a study with these patients, and you see there were 7 patients that we could follow up and examine later. This gives you just an impression of the demographic data. And I want to go on and show you how we can apply the botulinum toxin transorally. This is one of the methods that we use approximately just as much as we do it from the cricothyroid membrane, from the external approach. So you see, when you get the needle right into the vocal fold, then you're really sure that you hit the muscle, because below the epithelium there's nothing else but the vocalis muscle, and then you can be sure that you're in the right place. Whereas when you do it by electromyography, you just have the possibility to identify the muscle indirectly. So what you have to overcome is the gagging reflex, but in this patient, as you see, it was not a problem. And you see the voice sounds bad after the injection because the vocal fold is blown up with a botulinum toxin, 2.5 units per side. Okay, we tried to find out something for the outcome. We tried to find out the parameters that show us that our treatment is sufficient. And you see there is an arsenal of diagnostic means that we applied for these patients. And I would like to go on. We did the spasm count, which means that you are listening to the voice, and any time when you see during this text that is read during the connected speech that the patient hesitates somehow, and that is identified as a spasm, and the count of spasms shows a decrease after 1 month. So you know the course of botulinum toxin therapy is that first you feel nothing, and then after 1 week up to 2 weeks, the voice becomes very weak, and then it strengthens, and it normalizes at about 3 to 4 weeks after the injection. And the spasms disappear. This sound pressure range, the sound pressure level increases a little bit more too. And what you also can see, we measured the jitter of these patients, that it also is less after the intervention, after 1 month. And the DSI is actually some of different measures that we apply if we want to diagnose the voice and the DSI. The higher it is, the better it is, and it was in the case in this part too. Okay, if you ask the patient if he feels better or not, then you can see the voice handicap index with 9 items shows a slight decrease, but it's, as you can see, it is not significant. And when we look at the maximum phonation time, the change is also not significant. The F0 range, which means the vocal range from the lowest to the highest note, also did not change as an action of the botulinum injection. The communication participation item bank is also kind of a subjective assessment, like the voice handicap index, and it shows also no significant improvement, although there seems to be a tendency that the communication has improved a little bit. So the conclusions of this small study means that sound pressure level range increases, jitter decreases, spasm count shows less spasms after the Botox has come into action, and the voice strain assessment also shows less strain in the voice. So these are the best indicators, the spasm count and the voice strain assessment, whereas the other measures that we use usually for voice diagnostics, well, they seem to depict the improvement, but probably not as significant as we would like it, and that's why they are not good as outcome measures. And as you can see, especially the communication participation item bank, which is a subjective estimation of the patient itself, is probably too much affected by other characteristics not related to the Botox or to the spasmodic dysphonia. So let's come to another issue, which is the paralysis of the external branch of the superior laryngeal nerve, which is a diagnosis that is often overlooked because the vocal folds behave normally during respiration and phonation, but the patients suffer from a very soft and weak voice. They have no high notes and they have no volume. And unfortunately, I don't have a cure for this disease. I just show you the example where I have this lady. It's a rough and low voice after thyroid surgery. The external branch of the superior laryngeal nerve can be affected when you take out the thyroid gland and when you go to the upper part of the thyroid, and then it can be damaged, and this has really bad sequelae for the patient. Here you see the voice profile and shows you that there are no high notes any longer in this patient. Let's talk about vocal fold paralysis.
Ich habe leider nichts zu deiner Suche gefunden.
I'm sorry, somebody is here. So the most important causes of these paralyses are surgery of the thyroid gland, of cervical spine, trauma of the neck, idiopathic paralysis, laryngeal cyst, or long-term intubation. And unilateral vocal fold paralysis is characterized by a false position of one vocal fold. In this case, it's a paralysis of a patient who had a resection of his left lung, and that's why the left recurrent nerve was damaged. And you see there is no closure at all. You know that the best therapy that we know up to date is the medialization with thyroplasty and arytenoid adduction. You see, as much the patient can try as much as he wants, but he really cannot produce a normal voice. And this is after surgery. The voice is lower again, it's tight, and there is much more comfort for the patient to talk and speak. Okay, here's the speaking voice profile before the surgery, and this is afterwards, and you can see that there is really an improvement, that he really can utter different tones, different notes at different levels. Besides the medialization, as I told you, by thyroplasty and arytenoid adduction, which we mostly use, is the non-selective reinnervation, whereas an anastomosis between the ansa cervicalis or ansa hypoglossus and the stump of the recurrent nerve. That means that the recurrent nerve is anastomosed here, and this leads to an innervation of both of the muscles, the PCA and all the closing muscles. That means that the position probably is not much improved, but you have an innervation of the muscle and you avoid atrophy. And that means that the patient has probably a better phonation, and literature shows us that this is an successful procedure, however, not very often done in Europe. I've heard from colleagues in Asia and also in Britain, there is virtual, and in France, they are doing it, but many operations have been done in China, where I met a colleague in Shanghai who told about 3,000 procedures of this type. And I was very impressed by that. And that's why we thought we also have to start. And the first case was operated on in Berlin 2 weeks ago, and I'm proud to announce that here. So the non-selective reinnervation serves for the treatment of unilateral vocal fold paralysis. And now let's talk about the bilateral vocal fold paralysis, where we have different possibilities, but by now still we have to stick to the permanent transoral surgery, which means a permanent opening with the conventional methods, and I would like to show that to you. The glottal dilation with a laser is the therapy of choice for the treatment of the bilateral vocal paralysis, but there is also a new potential to implant the laryngeal pacemaker and to stimulate the posterior cricoarytenoid muscle. And we have evaluated both methods in 2 studies. So if you want to evaluate this, then you need some parameters, you need some outcome measures, like you see here 6-minute walk test, which shows you something about the respiration. You need something about the quality of life and about swallowing, which plays a role always in paralyzed larynx. So the functional parameters that we evaluated were laryngostroboscopy and voice diagnostic, as you can see here, what we usually do in every voice patient and other patients who get an intervention at the larynx, and spirometry, which is an evaluation of the respiratory function. So when we evaluate the larynx, then there is no common evaluation form yet. But what we think is important is the glottal width during respiration. Of course, we want to open the glottis when there's a bilateral vocal fold paralysis. We want to open it, and we want to keep it open during respiration so that the patient gets better. So, and then concerning the voice, it's important to know how much of the vocal fold is remaining after the intervention, and how mobile are these rests of the vocal fold or of the non-operated vocal fold. You see that it's very difficult and it's not standardized yet. So we only can give a try to an evaluation of the laryngoscopy. So let's have a look at the material and the methods. So we have 32 patients according to a protocol evaluated, and we have 7 patients with a laryngeal pacemaker, 5 female, 2 male patients, and we evaluated voice quality, laryngoscopy, and spirometry. So the conventional glottal enlargement is just inevitably associated with a deterioration of the voice, but it's still something that if you cannot do anything else, it's a method that you should offer to the patient. And from the plethora of methods that are available, the partial arytenoidectomy combined with a posterior cordectomy has proven to be beneficial. And I have done this kind of surgery since more than 30 years. And I think it's still a very reasonable procedure that I really can recommend. We take only the part of the arytenoid cartilage that protrudes into the glottal lumen, and we prevent aspiration by this method. Here is a picture that shows you the procedure as a graph, and the resulting of the voice quality depends on the compensatory capability. So how much can you leave of the vocal fold? For example, here in this drawing, you see there is nearly the whole vocal fold resected. Today, I do less. I do not take as much as shown here in this graph. I take only a small triangle from the posterior part of the vocal fold in order to preserve more of the vocal fold. In the anterior part, the lumen of the glottis is not so important. Most of the air goes in the cartilaginous part, in the posterior part of the glottis. And that's why this posterior part is more important to be widened than the anterior one. So this is the procedure itself. I can show you a short clip of the laser arytenoidectomy. I start at the vocal process and cut it laterally. Then I take out the vocal process of the arytenoid, and then there is a triangle cut into the posterior part of the vocal fold, of the membranous vocal fold. I take out the muscle, but only the posterior part of the muscle, not the whole. And then there is a flap in the middle, which is sutured laterally to the posterior part of the ventricular fold. So usually this is the idea that we think is good, because if you have a closed wound like this, you have less fibrin formation and you have less granulation. And what is, from my point of view, most important is that you have in the cartilaginous part a big hole where the patient can breathe, where you get enough air. And here you have an example before normal working vocal folds, and after surgery the vocal fold has been preserved, and the cartilaginous part, which is partly covered by the arytenoid cartilage, is open. And the patient can talk, but she cannot sing any longer because she lost some of her high notes. Anyway, she feels better with the voice, and I can show you also the voice range profile before surgery, and this is her voice before.
Der Nordwind und die Sonne. Einst stritten sich Nordwind und Sonne, wer von ihnen beiden wohl der Stärkere wäre. Als ein Wanderer, der in einem warmen Mantel gehüllt war, des Weges kam.
Okay, you hear the noise when she breathes. She only speaks in very short short passages, only a few words, and then you hear the inspiration. And this is after surgery, postoperatively, the voice.
Der Nordwind und die Sonne. Einst stritten sich Nordwind und Sonne, wer von ihnen beiden wohl der Stärkere wäre. Als ein Wanderer, der in einem warmen Mantel gehüllt war, des Weges kam.
Actually, from the point of view, the voice sounds very similar. It's much lower now, of course, and there is still some function of the voice, and the patient has better respiration. And this is actually what we are aiming at when we have patients that undergo this intervention. So now here you can see how much of the vocal fold has been resected in our series. So part only a fourth or half of it, or 3/4, or the whole of the vocal fold have been taken during the intervention. Not all of these patients were from Charité, but they also were from other centers in Germany. And here you still see the evaluation of the video stroboscopy, where we evaluate the mucosal wave, the vocal fold margin, the non-vibrating parts, and the duration of the closed phase. And the closure pattern is also important. And I would like to show you shortly the results. The glottal width has improved. And now I would like to give some more information on an alternative. If you do not want to resect some part of the vocal fold, then you have the laryngeal pacemaker, as we were talking about, but you also have the selective reinnervation. And this is a very complicated procedure from my point of view, but some people are able to do it. I just mentioned here Jean-Paul Marie and Keith Heathcote. They have written about it, and you can see that you can put to the recurrent nerve stump, you can put the phrenic nerve, which is usually used to innervate the diaphragm, and you can really suture it to the posterior part of the PCA muscle, and then you can root it with this green graft also to the other side, or you can take a Y-shaped graft and innervate both posterior cricoarytenoid muscles, both openers. I think a very, very complicated procedure. It's an extended open surgery which lasts up to 6 to 9 hours, and it has its disadvantages. Especially you need somebody who's very experienced doing it, and Jean-Paul Marie is one of them. And now I still want to say something about the laryngeal pacemaker. The feasibility study has been done in Gera, in Innsbruck, and in Würzburg. And from these 3 centers, we had patients for the laryngeal pacemaker, and the head and the machine. And actually, the actor is Andreas Müller from Gera, a very nice colleague. And I admire him very much, because he is really scenic, and he never gave up doing it. So in order to do that, we need to know something about the innervation of the larynx, especially of the posterior cricoarytenoid muscle. And this is by placing the EMG needle. And I want to give you some EMG results. This is an EMG that shows you the innervation of the thyroarytenoid muscle during phonation. That means the soft, middle, and the loud voice yield different innervation patterns.
Later.
So you can see the microphone signal and the EMG signal. So you see the recruitment of the muscle fibers here.
Later.
And now we would like to have a look at the posterior cricoarytenoid muscle, which is a little bit more difficult because it's very, it's not so easy to find signals during inspiration like here. And during phonation, the posterior cricoarytenoid muscle should not be active. This is, as we can see here, And we have one signal for the inspiration from the PCA.
Okay.
And now
Yep.
you can see during phonation there is no activity in the PCA, and during inspiration you see there is an activity. And this shows you that this muscle can be treated also. And here's still the graph where you can see how to come with the electrode to the PCA. You can go through the cricoid body and you can penetrate it, or you can go there laterally. I prefer the anterior way through the cricoid cartilage plate. So if we want to insert a laryngeal pacemaker, then we need to see if the muscle reacts, and the stimulation electrode is needed for that. And I'll show you how the stimulation works. So if you stimulate, then you see if the arytenoid cartilage moves laterally, then you have found the right spot. And then you know that if you insert there the pacemaker, then it will work and it will give you a result that shows that the implant has been successful. So before you do the pacemaker surgery, you have to check by stimulating with the electrode. And this is the equipment. And here's actually the way how it works. You go there with the electrode and you stimulate the PCA, and then it will open like here. So you can see that there is an abduction of the arytenoid. So here are the partners again, and here is the result of a stimulation of the implantation of the pacemaker. And here you also see that it has been published, the pacing from Andreas Müller, and you see that it is not opening when you breathe in or so, but it's opening at a certain rhythm. And the rhythm is determined by between 16 and 22 openings per minute. So the patient actually doesn't know when the larynx opens and when not, but they feel that there is a better breathing. And I think that they start breathing in when it opens involuntarily without noticing it. So, and now we had a comparison between the implantation of the pacemaker and the standard procedure, and I will go very quickly through these results, and I will show you just the end, the summary, which means the peak expiratory flow with the standard procedure of glottal opening was 44.4 or 44.5% of the normal value, and it improved after surgery. You always see before and after surgery these parameters. The inspiration is also improved in both cases. And if you look at these numbers, then you can see that the pacemaker of these 7 patients that we evaluated even was a little bit better than the standard, but you cannot say if this is significant or not. It's just a tendency. It's at least not worse. And this is very encouraging for us to go on with the pacemaker and to implant it later on. And so with people with bilateral vocal fold paralysis, both functions, the voice and the respiration, are impaired. And the subjective self-assessment after surgical glottal enlargement is better than the objective parameters indicate. That means we hear a bad voice, but the patient doesn't feel that the voice is so bad as we think it could be. And conventional surgical glottal enlargement still has its value. It has calculable advantages for respiration, and it has tolerable disadvantages for the voice. Tolerable ones. And the insertion of the laryngeal pacemaker seems to improve respiration to the same extent as the conventional surgery does, but the voice function is not impaired. So I've come to the end of my presentation. I would like to thank you very much. And now the floor is open for discussion.
So in the name of the UEP, I think we have to thank you very much for your excellent presentation, Tadeus. And I think we can now start with a discussion. For us, it's a premiere. And the first time that we just use this kind of medium. I think Ahmed has just collected some questions. He can start, or what do you think?
Yes, we have actually a number of questions coming from the participants, and I'm really thankful for all of them. Let us start by the first question that is coming, which is a question on the injection of Botox in the vocal folds. And actually, it's a question if you inject only in the vocal folds, or do you sometimes inject in the ventricles as well? And this is from Professor Abu Saad from Egypt.
Well, my answer is we usually take the vocal folds, but in some cases we have experienced that the ventricular folds are very well to be treated too, if the injection into the vocal folds does not suffice. If it's not sufficient, then we do that. And I have some patients where we regularly inject into the ventricular folds more than into the vocal folds, and that depends on the picture that we see from the laryngoscopy when the ventricular folds are very tight in adduction during the phonation. So that's why we do not do it always, but sometimes yet. In some cases, when we inject into the ventricular folds, we take less Botox because the muscle is smaller, and I think it doesn't need so much Botox like the vocalis muscle itself.
Thank you, Tadeus. And I'm really happy that we have all of these attendees. I'm really thankful for all of them. We have attendees from around the globe, actually, right now. It's wonderful to have about 70 attendants. One of the questions is coming from, related to this issue, on any sorts of Botox regarding the paradoxical vocal fold behavior.
Yes, we did it. We had a patient who did not respond to anything else, and so she got Botox, and that didn't help. And then we did an arytenoidectomy, and that did not help. So because she closed her false vocal folds then. The glottis was open, but the ventricular folds closed then. A very, very tough case. So you can try it, and you should try it, but you cannot be sure if it really works.
I use also for certain cases in which there is severe paradoxical movement of the vocal folds. I do Botox for the vocal folds, and I have about 3 cases that are coming regularly for them. And they are usually like young ladies who are suffering from severe VCD vocal cord dysfunction or paradoxical vocal fold movement.
Jörg, I see a question which belongs also to this theme, and this is the management of the abductor type of spasmodic dysphonia.
Yes, from Irina Hosevar, I guess, yes.
Yes, and this is actually, we have 2 patients that we follow up regularly. They come every 3 months or 3 to 6 months, and they get Botox injection into one PCA, one posterior cricoarytenoid muscle. And we usually take 5 units of Botox on this side, which paralyzes this side a little bit, but it does not impede respiration. And the patients, they do not get a normal voice, but they are quite satisfied with it, and they come back again, and that means that the treatment helps them.
I think they have now another question from Asta Elsa E to the first topic. It was about inducible laryngeal obstruction. The question is, what's the most reliable management of ILO?
Well, I cannot give a clear answer because I have seen 2 severe cases which we had to operate on and give a tracheostomy, and the other patients, they came and did not appear again when we advised them to respiration therapy.
What's interesting, you just said that it is a neurolaryngological problem. What do you think about the structure of the larynx? It's often young women who have got this ILO problems.
Yes, probably also sportsmen under exercises and younger people. Yes, younger people. I think it's an innervation problem coming from the central nervous system. I don't believe in a psychogenic reason.
Question from Sevtap Akbul from Turkey. She is asking if there is a difference in the efficiency of buttocks when you inject it through by EMG through the neck or transcutaneous, or when you do a transoral.
No, there's no difference.
Yeah. Also, we have another question, which is, what is your recommendation for the treatment of superior laryngeal nerve paralysis?
I think only exercises. There is no medical treatment. There is no surgery. I was thinking about cricothyroid approximation in order to elongate, to stretch the vocal folds, to make the tone a little bit higher and so on. But I didn't do that by now. The only thing that we can is hope and wait.
Another question is how you measure the width of the glottic gap in millimeter. Which method do you use?
Yes, this is a very tough question. we really
Odd
don't.
question.
I tell you, we just do it by estimation. It's a very, very rough estimation. And you always relate it to the length of the vocal fold. And if you have a female larynx, then you think the vocal fold is about 10 millimeters long. And then you compare it to the glottal width. And when you have a male, then you think about 13 to 14 millimeters. And this is actually, that's just roughly estimated by looking at.
But you don't use laser or something like this?
No, we would like
laser method.
We would like to have such an instrument, and in Germany, somebody once had it constructed, but this was good from Bonn, and but I never used it, and so I think it's only an estimation. It's very, very inaccurate. That's why we use the other measures, like, for example, peak expiratory flow, which is much more reliable.
We have also other questions coming up. One of the question is by Jakub Dersada from the Czech Republic on the vocal widening or the glottal widening. Do you use also lateral fixation? If so, can you shortly share your experience and compare this operation with laser chordectomy?
So lateral fixation is a way that leads to a dead-end street, I would say. I would never recommend to do that, because all the cases that I saw where so the dilation or the extension or the enlargement of the glottis was mostly in the membranous part. And there, this is the membranous part is important for the voice, not for respiration. And most of the times the arytenoid part, which closes the posterior part of the glottis, where the air has to go through, stayed in place, because the thread that you pull with which you pull the vocal fold aside, it cuts through the membranous part and it doesn't reach the cartilage, and that's why I think it's an inappropriate measure. I have seen many patients that I had to operate on later, and I think it's not recommended from my side.
We have also another question on the use of mitomycin in arytenoidectomy.
Why?
I guess I guess the idea some would be using it in order to lessen the granulation that sometimes is seen after arytenoidectomy.
Yeah, I showed you the video and the flap that we suture aside, and after we have started doing this, we have not seen serious granulation formation and also no fibrin, so that's why we don't need it. It's a question of technique.
Yeah, yeah, that's a very good idea, because I have to admit that I use it. So I use mitomycin, but I do it in a different way. So what I do is that I do not do the end part of your operation, which is in which you have the flap, and probably the reason is that I'm taking more. Usually for these patients, I'm doing posterior corductomy and taking a large part of their arytenoidectomy, which is, of course, for some patients is good, but for other patients, I would do sometimes the subtotal arytenoidectomy, in which I'm just taking behind the vocal process. So if the patient is, like on the edge, should like to have 2 millimeters more in order to be able to exercise and so on. So going behind the vocal process is sometimes, I guess, is good for the patient. So she's getting more open glottis, but at the same time, her voice is good.
Well, if I have a patient who says it's very important that I keep the voice as it is, then I agree with him to tailor the surgery to the arytenoid cartilage only. And I say, okay, then we'll take off the cartilage only, and we do not the posterior cordectomy. And anyway, also in these cases, I sutured the muscle or the vocal fold, the membranous part, to the lateral ventricular fold in the posterior part, and this really helps also. So you can adjust a little bit. You can make the operation so that there is much preserved of the structures that are important for the voice.
There's another question. I think it's a new question. What about lateral fixation by fixing threads through vocal process of arytenoid cartilage in order not to cut through the vocal fold? It's like a Lichtenberger method, or?
Yes, I know that there's the Lichtenberger method is what I do not recommend, but I have seen from a Hungarian colleague that he has a device constructed where he could pull really the arytenoid cartilage aside. But I have never seen results from this method. So the idea is good, to pull laterally only the cartilage and not vocal fold, but usually the thread slides forward to the membranous part and it doesn't stay there in place in the posterior part. So you should fix it differently. If you really want to fix the arytenoid, if you want to fix the cartilage and not the membranous vocal fold.
Mm-hmm. There's another interesting question from Irena from Slovenia. Have you ever tried unilateral Botox injection in the case of bilateral vocal fold paralysis?
Yes, we have tried it. We have not only injected into the vocal folds, but we also injected into the cricothyroid muscle in order to relax the vocal folds and to widen the glottis by that. We have done that a few times without success.
So it didn't help in your experience to
It didn't help in my experience. So
yeah.
Whoever wants to do it may try it, but if you ask me, I say don't do it.
Okay, but was it done? I mean, in bilateral vocal fold paralysis,
yes.
You did it on both sides.
Yes, we did it on both sides. Yes, not only on one side.
Yeah. And we have a last question, which is about the role of voice therapy as a in post surgery for some of these patients. Like I guess the question didn't specify the kind of patients, but I guess he or she is talking about some patients like with bilateral vocal fold paralysis, in which you are doing posterior cordectomy or others.
So voice therapy after that.
Yeah.
Yes, sure. The patients, they wake up and they have a very hoarse or no voice after the glottal enlargement. And then we have to promise them that the voice will come back, or at least a part of the voice will come back. Yes, it takes some time, sometimes a few days, sometimes a few weeks until 3 weeks, that if you have vibrational structures left, then the voice comes back, and there's the support of voice therapy is really important. And if you cannot achieve a phonation on the glottal level, then some of the people also develop a ventricular phonation, so that the ventricular folds start to vibrate, and this is a voice that's also quite acceptable.
We have also for the abductor spasmodic dysphonia, what is the dose of the products that you are using in the beginning, and do you do alternating sites?
We inject always on the same side, and we have one patient where we can inject it the patient is awake, sitting in the chair in front of us. We go like in the EMG testing of the PCA, we go through the cricoid cartilage, and we inject always the same side with 5 units. This is actually rule of thumb now. And the other patient we have to inject in general anesthesia, because she doesn't tolerate the intervention in local anesthesia.
Wonderful. I guess, do we have other questions, Jörg?
No, I have no questions. Here in my system, my chat system, I don't find any questions. You find?
I see right now there is one which is asking about, one which is asking, is laryngeal basing is done bilaterally?
Yes, it is planned to do it bilaterally when both vocal folds are still intact and the muscle is still working. But we are also thinking about doing laryngeal pacing in patients who have undergone arytenoidectomy on one side and the other side is still not mobile. So actually the system is meant to be used for both sides.
The question here, we also have a last question that I can see here, which is asking, how can you prevent getting cartilage pieces while doing Botox injection in the BCA muscle?
Well, you cannot do it. You just pierce through the cartilage, and good luck or bad luck. And then also,
yeah, that's I guess what we always experience, that when we go through the lumen, that we will go through the cartilage. Part of it will be inside. Sometimes you find, if the patient is coming regularly, so sometimes you find the same path, and you go.
But you know that we usually do it in a slightly rotating or twisting motion go through, and this is probably, that's why we didn't experience it so much. But I remember one time when a colleague started doing it, and he said, I can't inject. I have the signal of the muscle, but I can't inject. I said, push a little harder, and so it worked.
Yes, and it goes. Why there is the same setup is also asking, why don't you do the lateral approach?
I'm not sure that I would find the muscle there. I'm a little bit afraid of going the wrong way.
Wonderful. Jörg, do you have anything else to add?
No, nothing. It's first time. The webinar was excellent. A lot of participants, and COVID area, everybody just joining us. I hope also in future.
Yes.
So there's a new message. There's many thanks to the Professor Nawka. Yes.
And thank you too. And I'm really very overwhelmed of this big amount of attendees and of these interesting questions. Thank you very much too from my side.
No,
Thanks
we have
a lot.
To
we will be planning to have once a month a webinar, and we will be looking forward to also have recommendations on the topics that you'd like to listen to, and it's really wonderful to have you here. Thank you.
This nice library. Okay, thank you.
Okay, yes, all these books I have to read now during the Corona.
Yes.
Thank you. Goodbye, and have a wonderful Easter.
Goodbye.
Stay safe and be healthy. So bye-bye.